Hi, I'm Mike Brownfield. I'm Vice President of Communications at the Goldwater Institute. I'm here with Dr. Jeffrey Singer. Jeff is a senior fellow at the Cato Institute, and he works in the Department of Health Policy Studies. He's also a visiting fellow at the Goldwater Institute. He's President Emeritus and founder of Valley Surgical Clinics Limited, the largest and oldest group private surgical practice in Arizona. And he's been in private practice as a general surgeon for more than 35 years. And he has a new book out. It's called Your Body, Your Healthcare. And it's an excellent book that looks at the way the government stands in the way of your ability to make decisions about your healthcare. So we're really excited to have you today. Thank you so much for joining us.
I appreciate you doing this.
So, Jeff, could you start with, most folks aren't expecting their doctor to be involved in public policy or writing books about what government policy should be. So can you tell us a little bit about, well, how you got into that and how you arrived at this book?
Yeah, I guess I'm not a typical doctor. Ever since I was a young kid in my family, I grew up in New York City, and there were all these political arguments taking place in the family, and I didn't understand half of them. But I sort of marinated in an environment where I picked up the idea that public policy and political issues are important. I always wanted to be a doctor, and when I was an undergrad in the late '60s, early '70s at Brooklyn College, uh, even though I was a pre-med student and I was very direction oriented towards going to med school, I still got involved with a lot of the debates at that time because that was my other passion. And of course, once you get into med school and then do your residency, there's not a lot of time for that. You got to stay focused, but I didn't lose my interest, and I continued reading during my free time and subscribing to different publications like Reason magazine, which was one of the few libertarian publications in those days. And then when I started my practice here in Phoenix, I did my residency at the Maricopa County Hospital, '76 to '81. Started my practice as a general surgeon solo, because that's the way it was done then. Gradually merged with two other solo surgeons, grew it into a very large practice. And then in the '90s or so, as the practice really matured, we added more doctors. We each had enough time to give each other a personal day. So unlike my partners who were normal, who would do things on their personal day that, like play golf, meet with friends, have lunch, run errands. On my personal day, I saw that as an opportunity to get back involved in my other passion. So starting in the '90s, I was writing letters to the editor. I was getting op-eds published in the Arizona Republic. I got involved with the Goldwater Institute. I served on the board for a while, and I got just more and more active. And then in the early 2000s or mid 2000s, around 2010 or so, I became an adjunct scholar at the Cato Institute while I was a visiting fellow here. And then as I reached, I would say, the autumn of my years, or it's not the winter, I hope. As I was approaching 65, I was thinking to myself, my wife and I are empty nesters. My kids are all grown up with their own lives and could take care of themselves. And I'm ready to kind of open up a new chapter in my life. So
golf.
no.
No. Oh, okay.
So I approached the Cato people and said, look, I've been an adjunct here for a while. What would you say about raising that level of work up to a higher level? Because I don't think there are too many think tanks in the country that have people dealing with health policy that are actually clinicians who take care of patients. There are some that have some doctors, but in many cases, those are administrative doctors like Dr. Fauci.
Yeah.
But actual people who go to work taking care of patients, it's an interesting perspective that you could add. They saw the value in that, so I became a senior fellow, and I informed my partners that effective the date that I became a senior fellow, I wanted to scale back the practice. So now I work in the practice on 2 days a week. I'm limiting my surgery only to outpatient surgeries that are low risk, because it would be unethical to do major surgery and then not be able to provide the attention to the patients that they need. And I do consultations and post and pre-op visits on the other day. And the rest of the time, I'm working remotely for the Cato Institute. I have a home office where I do most of my work. I have a team of research associates at Cato who help me, and I'm in touch regularly with the staff there. And in recent years, I've had to make more and more frequent visits to Washington on Cato business, and that's what I'm doing for the last 8 years.
So this book it's fantastic, and I recommend everybody pick up a copy. You're focused on your personal autonomy and how the government is getting in the way of your ability to make decisions about your healthcare. And I don't think most folks, I think because we just kind of live in the era that we're in, may not even be aware that
Right.
how the government is getting involved. But first off, before getting there, what is just personal autonomy, and like what are the kind of like you talk about informed decisions? What's this all
Yeah.
about?
Well, it's a fundamental principle of classical liberal thought that we own ourselves, self-ownership. We have autonomy, so what I thought would be valuable is because we tend, when we're dealing with health policy, to get kind of into the weeds. It gets a little wonky, and sometimes we lose sight what this is all supposed to be about. So that's what I was hoping my contribution would be. So I opened the book in the introduction talking about how we doctors nowadays, we have it drilled into us from the first day of medical school that we have to respect our patients' autonomy, that we can't order a test or perform a procedure or do anything to them without their fully informed consent. And if they don't give us their consent, even if we think they're making the biggest mistake in the world, we just have to respect that. And that's what we have drilled into us. But that's actually a relatively recent development. In fact, even when I was in medical school, that still wasn't kind of the conventional approach. It was a new thing. As recently as the 1970s, a survey of oncologists published in the Journal of Oncology found 60% of them actually admitted that they don't tell their patients how bad their cancer is and what the prognosis is because they'd be afraid it would discourage them from cooperating in the treatment plan they think they
That's
need.
incredible.
And that was as recently as the 70s.
Yeah.
And we hear stories about there was the infamous Tuskegee experiment
Right.
where public health officials, doctors were withholding information from patients that they could cure their syphilis because they wanted to see how it goes from beginning to end. The Nuremberg war crime trials, forced sterilization, all these kind of things. So this is into the late 20th century, mid to late 20th century. But things began to change, and this is how we get into the book. There was a very a very landmark case in around originally 1908. A woman named Mary Schlowendorf, and probably most lawyers learned this in law school, I would think. So she was in New York City, and in those days we didn't have CAT scans and all these MRIs. So it was very common to do what was called an examination under anesthesia. We still rarely do that, but not very often. Where if you put the person under anesthesia and all their muscles are soft, you could actually get a pretty detailed abdominal exam. You can feel their organs. So this doctor suspected that she had a uterine tumor and asked for permission to do an exam under anesthesia to confirm it. And she said, yes, but under one condition. If you find anything, I don't want you to do anything to me. I just want you to wake me up, tell me what you found, and then we'll discuss where to go from there. So he took her to the operating room, put her under anesthesia, palpated a uterine tumor, went ahead and did a hysterectomy without her consent, of
Wow.
course. She had all sorts of complications. She recovered, but she was very upset. And
Well, can you imagine just waking up and like all this done to
but
you, right?
that was common in those days. The
Yeah.
doctor knows best. The doctor's going to do what's best for you. So, but she was upset and she sued, and she won on the first round. And it was called Schlowendorf versus Society of New York Hospital. And then the hospital appealed, and it went to the appeals court. And in the writing for the majority, then appeals court judge Benjamin Cardozo, who later became a very highly respected Supreme Court justice,
Mhm.
wrote, and now I'm paraphrasing, but you can see the exact quote in the book. He basically said every person of sound mind owns their own body, and to do something to them without their informed consent constitutes an assault, and that Mary Schlowendorf was assaulted. And that was like the first time, and probably the most eloquent time, that principle of informed consent got stated. And there were several other cases percolating up around that
Mhm.
same time, similar cases, but none of them probably as eloquently stated as Judge Cardozo. But it took until, like I say, until maybe the last 40 years or so that If you ask a young doctor today, that they'll probably be surprised to learn this is not the way we used to approach things. So what I point out in the book, I use that as a jumping off point. I say, well, my profession finally got it. So they're drilling this into us. But there's another person in the exam room all the time. It's called the government. And the government didn't get it because every day the government does to us what Mary Slowendorf's doctors did to Mary Slowendorf. The government tells us, for example, what kind of health professional we will be allowed to seek advice from. It tells us what kind of medication we're going to be allowed to take, even if a medication has been proven to help people in other countries. The government may say, well, we're not convinced it works, so you can't have it. Or if we can have it, it tells us we can only have it if we get a permission slip from another autonomous adult like ourselves called a licensed healthcare professional. The permission slip is another way of saying a prescription. It also tells us what even when we're not talking about medication, what we can put into our body for whatever, either to self-medicate or because we like the feeling it gives us. It tells us that whether or not we can take certain steps to reduce the risks of some of those decisions as to what we can put on our body. So in summary, the government does to us what Mary Slowendorf's doctors did to her. And then what I do is I'm working at the Cato Institute over these last 8 years now. The areas of policy that I focus on are medical licensing laws and scope of practice, FDA regulation, the overdose crisis and drug prohibition, tobacco policy, tobacco harm reduction for other drugs. Those are the areas I work on. So what I do is I take all those, each of those is a different chapter of the book, and I kind of link them together and constantly weave in my personal experiences and reflections as a person who takes care of patients. But I constantly bring it back to this is all about somebody else telling us what we as autonomous adults can do.
So you mentioned people can't see the kind of professional that they would want to see because of government regulation. So, but we're not aware of what we can't do necessarily. So what's a limitation right now? And like, how could that be different?
Okay, well, talk about scope of practice law.
All right.
Okay? So, well, I'll back up a little more. Many people, this is the hardest anti-occupational licensing issue to sell, because people can't imagine a doctor not being licensed. But it wasn't until the American Medical Association was founded in the 1840s, and its mission statement was to get doctors licensed. There was no such thing as licensing doctors in those days. And in those days, when we didn't know as much, there were about 4 or 5 equally prominent competing schools of thought on how to treat conditions. And so the AMA began a process. It took until the late 19th century, early 20th century, where state by state they had chapters working on state legislatures to get laws passed saying you can't practice medicine unless you have a license from the board. And the board at those days consisted of members of the state chapter of the AMA. And in order to get a license, you had to go graduate from an AMA accredited medical school and then do a residency at AMA accredited residency program and pass, of course, the standardized test that was developed by an AMA affiliated.
But that had the force of law because they were lobbying. And you mentioned in your book about how that was used actually to create a segregated healthcare system in the South.
Oh, yeah. Well, yeah. But it was also created a cartel. It's a cartel. So, yeah. But in the South, for example, and it doesn't have to be that way, but these things happen. So in a lot of poor Black communities in the South in the Jim Crow days, it was medical schools weren't accepting Blacks, and some who got in, there's historically Black medical universities that started medical schools too. Well, in order to get a license, you have to do a residency. So let's say you came from a 99% African American community in rural Mississippi, and you were smart enough and resourceful enough that you got yourself accepted to Harvard Medical School. You graduate, you want to come back and be the doctor for your town, but they won't give you a license unless you do a residency, and you can't get into a residency program down there because none of them are accepting Blacks into their residency program. So there are things like that.
But so today it's rural communities are lacking care because there's not enough medical professionals, right? Or there's issues with accessing mental health care, right? Because
Right.
so can you talk about how some like how because like the licensing scheme sort of restricts the supply and folks can't get the care that they
Yeah, it's
need?
basically a protectionist thing. So, for example, in the early days, these other kind of ancillary health fields weren't as sophisticated as they are now. So now, for example, let me just pick the example of nurse practitioners. Now, Arizona is pretty good on this,
Mm.
but
Well, that's because of the Goldwater Institute. But
exactly. But in about close to half the states in this country, if you got, this is called advanced uh, practice nurse, APRN, advanced practice registered nurses. These are nurses who've done extra training. Most of them are involved in primary care, which is the most, necessary position right now. We have a huge shortage of primary care clinicians. So in about half the states, you can't go out on your own and practice primary care as a nurse practitioner. You have to sign, you either have to work in a doctor's office or sign some sort of a contract where this doctor technically oversees you. Now, in some states, the contract doesn't even require the doctor to be 50 miles from you. So basically, you got to pay tribute to the doctor in order for you to practice. They get a percentage. It's sort of like
mm.
when Tony Soprano wants to help your business succeed. So
And with your New York background, you can
yeah,
speak.
I could definitely relate. So, but the point is that these are people who could be. There's a lot of research now. The AMA is going to be very upset hearing me say this, but there's actually good empirical research suggesting, at least when it comes to primary care, nurse practitioners seem to be as good as physicians. Okay. Now, yeah, first of all, as an autonomous adult, I should be allowed, this government shouldn't stop me from deciding whether I want to go see a nurse practitioner for my everyday primary care stuff or an MD or DO for that. That should be my decision. But in about half the states, the government is saying, well, we don't think a nurse practitioner is good enough for you, so we're not going to let you do that. And in some communities, people are going without only because the government doesn't think that the person they're perfectly comfortable getting advice from is good enough from them. Well, I would argue that that's assaulting our autonomy because even if the government doesn't think I'm making a good choice by choosing to go to a nurse practitioner, that's my choice. Just like as a doctor, even if I think the patient is making a very bad decision by not following my medical advice, I have to respect their choice. It's the same principle.
So another thing that you talk about in your book is certificate of need laws.
Yeah.
And this is something we've worked on a bit at the Goldwater Institute. A few years ago, we did a report investigating the impact of these laws, which restrict the supply of medical services. And there was a child in Iowa who assaulted his mom. He was mentally ill. He needed to be checked into a mental hospital. And because of certificate of need, there just weren't enough beds. And he wound up being locked up to a bed in a hospital. He spent days in prison because there was nowhere for him to go. So talk about like what is certificate of need and just
Yeah, there are examples like that. They abound. There are stories of women who've had, uh, postnatal births, fatalities, because they couldn't get transferred quickly enough to a neonatal ICU because the hospital they delivered at wanted to add on neonatal ICU beds, but the Certificate of Need Commission said we don't need that.
what is that?
Yeah,
So like if
basically, it's based on this idea that arose in the Nixon years, Nixon administration, that because already healthcare costs were rising with the advent of Medicare and Medicaid, the government was spending a lot of money on healthcare they didn't anticipate. So they figured, well, if we can reduce the amount of healthcare services available to people, then maybe people will use less of them and we'll save money.
so reduce
Yeah,
supply
yeah.
and you're gonna
It-
like reduce
yeah,
cost.
that's right. That's right. Yeah. So I know first that was my first reaction.
Right.
So they actually gave out grants to states to set up certificate of need commissions to do that. For some reason, Louisiana never did. All the other states,
Huh.
including Arizona, did. And then by the mid 80s, it became apparent that it wasn't working. One other thing they didn't take into account is that we now have a third party payer system. So the great majority of expenses are paid for by a third party, not by the end user. So even if by tightening up the supply, you could raise the price, the person who's consuming it really doesn't care what the price is, as long as the insurance company's paying for it, really doesn't matter to the consumer. And that's another reason why it didn't work.
But so it's like it's clear that it
Yeah.
doesn't work,
Right,
and it's seen that where this is in place, the
right,
costs are going up. There's a constricted supply, and actually federal policy changed. We're like,
right.
but 38 states
Yeah,
still have
yeah,
these. So why?
yeah.
Like what
Well, because the incumbents love it. So during the Reagan
the
years is when it was
incumbents
repealed.
being like
But
the hospitals?
mostly the hospitals,
Yeah.
yeah. So Arizona, I'm happy to say, around 1990 ended its con laws. California doesn't have con laws, but most states do. And what happens is you go before, well, just for people that want to know how it works, I use in my book the example of, say I want to open up a restaurant, and we had restaurant certificate of need laws. And the certificate of need commission consisted of the major restaurant owners in the state and maybe some local people. And so I got this new concept, and I want to open it up, and I have to go to the commission, and the commission says, yeah, we don't need another one like that. So
We've
we're
got enough
rejecting it.
pizza.
Yeah, yeah. We
Mhm.
got enough pizza places. The pizza and and Domino's Pizza is one of the members of the commission, something like that. So that's what it is with the hospitals. So the hospitals convince lawmakers that if they didn't have this sort of veto power over competitors, then they wouldn't be able to make enough money to make ends meet under because Medicare and Medicaid don't pay them enough. So therefore, they need and of course, they try to make it very altruistic sounding. So in order for us to be able to serve this community, you have to shelter us from any competition, or we wouldn't be able to afford to keep serving this community. And that usually works. I testified remotely before the Kentucky legislature. Kentucky is one of the worst states. They have con laws on a whole lot more things than many other states do. And the representative of the hospital association there, he was explicit. He said, in some of the rural parts of our state, almost all of our patients are Medicaid patients. And if we had, as you probably know, a lot of things, ambulatory surgery centers,
Yeah.
surgery centers, they could oftentimes be much less expensive, more cost effective and efficient than a big hospital for outpatient procedures. And if we allowed those to compete with us, then we wouldn't make enough money, and we have trouble serving the people of rural Kentucky.
Well, COVID showed what happens, the consequence of not having
There
an
weren't enough facilities,
yeah,
right? And some states relaxed it, at least during the pandemic.
yeah.
So I countered with, doctors could make the same argument. They could say, doctors also in those parts of the state are getting mainly paid by Medicaid patients, so they're not making a lot of money too. If the Kentucky Medical Association proposed that they should pass a law saying no new doctors in the state of Kentucky unless the Kentucky Medical Association serves on a commission to say whether or not we need another doctor in that part of the state, you guys would, first of all, think it's absurd, wouldn't you? Well, that's the argument the Hospital Association is giving you. It turns out the Hospital Association won that round. They still have that law in place, but that's contributing to the shortage, and also to options. For example, in many states, they have these birthing centers that are developing. You need a certificate of need law in some states to open up a birthing center, which are a lot of women prefer now not to go to a hospital to have their babies. And in some rural areas of this country, particularly like in Appalachia and the South, some of these birthing centers are much more culturally connected to the population there too. They feel more comfortable there.
Mhm.
But you need certificate of need laws, and a lot of hospitals that have obstetrics wards don't like that, so they'll oftentimes veto it. So basically, in fact, if I think Christina Sandifer here at Cato, I'm sorry, Habit here at the Goldwater Institute, famously writing about this, called it the competitor's veto, which I actually quote her saying that in my book. Props to Goldwater Institute and Christina Sandifer.
Thank you. So you would say the word options. And one of those areas that we work on here at Goldwater a lot is with in the area of right to try and the ability for patients, terminally ill patients, to access treatment that could save their life.
Mhm.
And they don't have the option to access that treatment because the FDA
Yeah.
is standing in the way. Can you talk about the FDA and what is the rationale? It wasn't always
No.
like that, right?
Yeah.
How did that come about? And what can be done?
I get into two chapters on that in the book, one on the prescription power and one on just the FDA in general.
Yeah.
But a lot of people don't realize that up until 1938, there were other ways of vetting drugs. In fact, I just finished saying bad things about the AMA, but to their credit, they had a Council on Pharmacy and Chemistry, that was just one of the vetting organizations. And they said to all of the pharmaceutical companies, we are not going to designate you as an ethical pharmaceutical company unless you let us review all your data on your drugs. And not only that, we're not going to let you advertise in any one of the numerous medical journals that our members read, so it won't be as easy for them to find out about your product. But it's up to you. And
Mhm.
so many of the big companies we have today said we want to be ethical companies like Pfizer and Merck. But so that was already around. That closed up in the 1950s because the FDA sort of made them sort of superfluous. But in 1938, Congress passed the Food, Drug, and Cosmetic Act. And it said that from this point forward, all new drugs, and I explained what made the circumstances around it, but I'm trying to be a little economical with time here. All new drugs cannot be sold to anybody unless we're convinced they're safe. That's all it said. And it said that any drug currently out there is grandfathered from that. So that's why aspirin didn't have to get FDA approved. In fact, two brands of insulin to this day are over the counter.
Hmm.
Most people don't know that.
It's just because it went back so far.
It was, yeah, around World War I is when it came out. So old school NPH and regular insulin, you could at Walmart pharmacy, I think they have a brand, I think they call it Rely On. You can get it, it's behind the counter, you can ask the pharmacist for it. So you don't have to get a prescription. So those two insulins are exempt. But every point thereafter, you had to get the FDA to approve it. And that, of course, just from an autonomy standpoint, my reaction to that is, well, look, I really, if you provide me with information on the safety profile of this drug, that's useful information to me as an autonomous adult to use. And I'm very grateful to have that information. But I'll still decide if I want to go ahead and use it, despite what you think. That's still my choice. Then in what happened was up until 1951, people don't know this, um, the pharmaceutical companies on their own would decide whether something would be sold over the counter or by prescription only. It was basically the FDA required that if you're going to sell, it's up to you, but if you're going to sell it over the counter, you have to convince us that the label on it is easy enough for a person with the most rudimentary education to understand how to use it right. And so some pharmaceutical companies went ahead and did that. Their legal people would say, you know what, somebody's going to get confused, we're going to get sued. And what they would say to the pharmacist is, you can't sell this to anybody unless they have a prescription, which helps protect the pharmaceutical company because now somebody's
So the risk of like tort liability is enough
liability and
protection.
reputation.
Yeah.
So then what was happening was, and of course, this wouldn't happen today with our modern technology, but some pharmacists were making mistakes because, company A, they didn't require a prescription, but company B that made the same thing did. And sometimes they'd make a mistake. And so the two people in Congress for pharmacists to go to was Senator Hubert Humphrey of Minnesota, who was a pharmacist before he got into politics, and Senator Carl Durham of North Carolina. And so they fixed that right away. They said, okay, starting now, the FDA is going to decide whether it's prescription only or over the counter. That's taken out of the hands of the private sector and the market system and the civil tort system. And so to this day, that's why when you put in a new drug application, you have to say what you want it for, and then the FDA gives you permission. And then it got worse. In 1962, there were the Kefauver-Harris amendments to the Food, Drug, and Cosmetic Act. And this came about after the very famous thalidomide scare. There was a drug called thalidomide, which was very effective for treating nausea, and it was recommended for treating nausea of pregnancy, morning sickness. It hadn't yet been approved in this country, but some doctors were handing it out as samples without telling the patient it hadn't yet been approved in this country, which was not informed consent, right? And they would just say, here, try this. This is something new coming out.
And you make the point in the book that these were government approved doctors.
Yes,
Right. So they
right.
were
Licensed
licensed, right?
exactly, exactly. Government approved that. Meanwhile, in Europe, it was allowed, and there were a whole bunch of horrific birth defects that we all know about. So uh, instead of saying, "Well, good thing the FDA didn't approve that one yet," um, Congress has to do something all the time, especially when it gets a lot of news coverage. So they pass these amendments, and I don't understand why these amendments said this. They said, okay, from this time forward, you have to convince us that it's not only safe, but that it's efficacious for what you designed it for. And the answer to that was, well, it was efficacious. Thalidomide is a very effective nausea medicine. Just don't take it if you're pregnant. So, I don't understand the logic there, but that added on several more years and millions and millions of dollars to the drug approval process, which from the standpoint of patient autonomy, that meant it delayed even more years my opportunity to access something that might be able to help me because the FDA had to be convinced. And then there's a lot of, kind of irony in this law. So for example, um, when you apply for the drug, you have to say in your application what the drug is for. And so that's what the efficacy tests are all about, that works to treat this problem.
Mhm.
So when the FDA approves it, it'll say on the label, this is approved for the treatment of condition A. Now, if you use it for anything else, that's called off-label use because it doesn't say that on the label. Well, 20% of medications prescribed in this country are prescribed for off-label uses. Happens all the time. And as far as the FDA is concerned, that's fine. You're the doctor. If you understanding how the drug works, you're reading uh, clinical research in the literature saying this also seems to work for this, then who are we, the government, to tell you, doctor, whether or not you can prescribe it? Okay, well, that's how you feel about conditions B through Z, then why did I have to wait 12 years for you to say it's okay for me to use it for condition A? Right? There's no logic there. So, but that's what's happening. So you trust my judgment on everything except what's on that label I had to wait for. So
So
that,
you talk about drug loss and drug lag,
Mhm.
right, in the book, and then also how there's certain prescriptions that really should be making their way to people more accessibly. So
Yeah,
birth control is a good
yeah,
example. Can you talk
yeah.
about how government barriers have made it impossible for something that is treated so differently in different countries?
Okay, so quickly, the drug loss, drug
Yeah,
lag,
yeah,
it's more of an economic
yeah.
thing, but
Mhm.
basically a drug loss refers to when when the FDA is requiring all these additional years and costs of to get approval. That's money that these pharmaceutical companies are spending on this that might have otherwise gone to new discoveries of other drugs. And that's the seen and the unseen, as economists talk about. So we'll never know how many drugs didn't get developed because so much money was spent unnecessarily on that. And the drug lag is that how many years people, when the drug is finally approved to treat some serious condition, how many people suffered or died waiting for the government to say, okay, now you can use it, when people in other countries might have been able to use it already.
Which is
That's drug
exactly what
lag.
our right to try is all about, was
Exactly,
ensuring that
exactly.
people can access that without having to spend hundreds of thousands of dollars to go to other countries when it could be available right here and right
Exactly.
now.
And then the other thing you're talking about, well, when you have a government monopoly making the decision regarding what's over the counter and what's prescription only, there's no way it's not going to be vulnerable to special interest pleading and to political considerations. It's unavoidable. Whereas in the old system where a pharmaceutical company could make the decision, and maybe when it's off patent, a generic competitor could decide to come in and offer its version over the counter, which might pressure the original patent holder to say, well, we may make ours over the counter too, because markets would be working and all that. Instead, you have one monopoly deciding this. So, for example, in 100 countries, women can get hormonal contraceptive, birth control pills over the counter without a prescription. The American College of OBGYNs, the American Academy of Family Physicians, and the AMA have said for years now, you don't need to come to see us and get an exam for this. You should be able to get this over the counter. They've been saying this in their statements repeatedly. And that means something because every time you come to a doctor, they charge you for a visit and to write the prescription. And they're by saying you don't need to come to me, they're actually their motivation is the other way around, right? Saying, oh no, you should come to me. So they're saying this, yet to this day, finally, about a year ago, the FDA allowed one brand of one type of hormonal contraceptive, the so-called mini pill. The brand is O pill. They're allowing women to get access to that. Now, the reason why that's not very popular is because it's a progestin-only pill as opposed to the combination hormonal birth control pills. And you have to take it within a 3-hour window, the same 3-hour window every day. If you miss that 3-hour window, then you got to stop, finish the cycle, and start all over again. It's that crucial.
Mhm.
So that's why it's not going to be taking off, because it's not convenient. Meanwhile, in 100 countries, and you can go drive to Nogales and get it if you live here in Arizona. There's one example. Another good example would be naloxone, which is the antidote to an opioid overdose. So that's been around since the 1970s. And there's both the injectable type and the nasal spray type. So as far back as 2016, the FDA said, it's been around long enough, used by enough first responders, et cetera. We think this should be over the counter. The FDA said that. And we invite the makers of Narcan nasal spray to ask us to make it over the counter. And they didn't. Why? Because we have a third-party payer system, and they could overcharge a third-party payer for a prescription-only drug. Insurance companies don't necessarily cover over-the-counter drugs, whereas if they sell to the regular end user, they may have to lower their price or nobody's going to buy it. So they weren't in a hurry. Now, I had written about this a lot, saying, why are you asking the Narcan makers to ask you? You could just decide to do this. The commissioner could decide, or any interested party could petition the FDA commissioner to consider making it over the counter. But there's regulatory capture, which is what always happens when you have regulation of industries. So there's a tendency to defer to the pharmaceutical companies you're regulating. So they were being nice and asking. And they were bending over backwards. As late as 2019, Commissioner Gottlieb said, look, we don't usually do this. If you're gonna ask us to make it over the counter, we would want to see how your labeling is.
Yeah.
And we went to the trouble of coming up with a label so that you don't even have to go through that expense. We already know this label will be good enough. All you have to do is just formally request us to make it over the counter. And they still didn't. And then finally, I think it was 2023, in late 2022 and early 2023, a generic maker of naloxone nasal spray made an application to the FDA for over the counter. And this is what got them, this had a little fuse under the Narcan. They announced, look, we're reviewing this over the counter application. And right now it looks like we're going to approve it. If we do, we don't see why any other nasal spray, Narcan nasal spray shouldn't be over the counter. So basically they were warning the makers of Narcan, you're going to have competition soon. And so Narcan immediately applied for over-the-counter status. And so now the Narcan nasal spray, starting in mid 23, you can get that over the counter. Still, I actually work with, there's a very large established harm reduction organization here in Arizona called Sonoran Prevention Works. And the injectable is still prescription only. And the way around that, every state has passed legislation as a workaround. They say if a doctor signs what's called a standing order, which basically says, I'll be the official prescriber, you can distribute it to people showing up, then it's still prescribed technically, but it's helping to get around that bottleneck. So for Sonoran Prevention Work, I sign it, the standing order. So they approached me and said, would you sign a standing order again for injectable naloxone? Because we give out these auto-inject naloxone to people. And I said, but Narcan's over the counter now. And they said, yeah, but the nasal spray is still expensive and it's so cheap, the injectable type, and we're on a tight budget. We rely only on donations. So even though we can purchase naloxone without having to ask you to prescribe it, we can't do that with the injectable, so we need you to sign a standing order. So I do. But why don't they make that over the counter?
Well, you also mentioned in your book about Claritin, how simultaneously the drug company is lobbying for it to be prescription only in the US, but over the counter in Europe. But they changed their tune. Like, why?
Yeah, well, people may not know this. Claritin and Allegra and Zyrtec are what they call non-sedative antihistamines. So they came out in the 90s, and up until then, the antihistamines were very sedative. In fact, Benadryl, which is an antihistamine, the FAA won't let commercial pilots fly an airline if they've taken Benadryl in the last 24 hours because it may make them too drowsy. Okay. So that was okay to have over the counter, but you need a prescription for the one that doesn't do anything like that. Okay. And the company was Shearing Plow. They were one of the companies, WellPoint, which was a health insurance plan. They were just getting inundated with these prescriptions for Claritin. So they petitioned the FDA to make it over the counter because they were having to pay for the Claritin and they'd rather not pay for it because they covered all prescription drugs. So Shearing Plow testified before the FDA saying, oh, it's not safe. You shouldn't allow it to be over the counter. At the same time, Shearing Plow was busy before the European versions of the FDA, telling them this is great stuff for over the counter. It's safer than the Benadryl, and you should sell it. And they were selling it over the counter in Europe at Shearing Plow's advice. It wasn't until Claritin had now become off patent, and there were generic competitors coming in, and Claritin, the Shearing Plow developed a new non-sedative antihistamine that got a patent on it, they could make prescription only, that they relented. And because they figured by this time, Claritin has got such a good brand name that when we compete with over-the-counter Benadryl, everybody's going to know Claritin.
Oh, they'll get the halo effect
We'll,
of the
yeah, we'll
brand.
get the effect of that. So,
Okay.
but there's an example. This is what happens when you have a monopoly that's government. I mean, no matter, you can have
So what's the alternative?
the alternative is the way it was before, where you had private, independent, third-party accreditors and credentialers, like the AMA's Council on Pharmacy and Chemistry, the U.S. Pharmacopoeia, which was adopted by the FDA, which lists all of the different pharmaceuticals in a compendium. There are a whole bunch of different organizations that were and would be, now they're preempted, that could be doing the vetting, but there's no one person that makes the monopoly decision for everyone else. And then doctors would be able to say to their patients, there's this drug that's made by this and this company that I think would be a good one for you. And they don't have to get permission from the FDA to do that. Now, that's going to be politically, that's a heavy lift, but there is a reform proposal I discuss in my book that is actually, it's been introduced since 2011, 3 or 4 times, that at least moves in that direction. That's what they call reciprocity, which is not the ideal name because reciprocity suggests you do this for me, I do this for you. But basically, the proposal is that people should be able to have access to drugs that are not only FDA approved, but approved by the FDA equivalent agencies of a list of similarly advanced countries, like Canada, UK, European Medicines Association, Israel, Japan, countries like that, Australia, New Zealand. And so you'd be able, your doctor would know about these different drugs that are available, and you could be able to get a drug that may say on, and it could be either a prescription drug or an over-the-counter drug, would have to say not FDA approved, approved by Health Canada, or approved by the UK, whatever their organization is called, et cetera. And then you, in consultation with your doctor, decide, this one isn't FDA approved, but it's approved in the UK. Are you sure it's safe? And your doctor may say, yeah, I've looked at it. Yeah, I recommend this drug. And that's the way so at least it's opening things up. And also that would create competition with the FDA. So it would kind of be an incentive for them to kind of speed up the approval process. And guess who's going to be there are going to be 2 people against that idea. One is going to be the drug companies because that's more competition, more choice from other drugs available in other countries. But 2 is the FDA. The FDA is not going to want to give up that power.
So there's a huge movement for reform at the FDA right now with RFK Jr., right? Now,
Right.
What's your take on the ideas that are being proposed there?
Well, it's a mixed bag,
Yeah.
and I have a lot of trepidation. First, I like the idea of, for example, when RFK Jr. was running for president as a Democrat, he was in a town hall on News Nation, and he said, look, we're adults here. Medicine is not a priesthood. Everybody should do their own research and make their own decisions. And I'm thinking, well, that's exactly what I'm writing about in my book. But so I like that. But then later on in the same town hall, and now I just heard recently, he's calling for not allowing direct-to-consumer advertising by the pharmaceutical companies. Now, set aside the First Amendment issues surrounding that, because the Supreme Court has already decided in the past that that's free speech, commercial speech, as long as it's honest.
Mhm.
Um, but set aside that, well, if you think that I should do my own research and make my own healthcare decisions, and that medicine is not a priesthood, then how come you don't want anybody but the priesthood to know about those medications? You're not allowed, you don't want me to have access to that information. So there's a contradiction. Some of the things, like I say, the some of the other appointees, like Dr. Marty McCary, Dr. Jay Bhattacharya, these are people who actually have a record of being evidence-based people who appreciate how markets work. So there's I'm encouraged by their appointments. But what I'm worried I'm hearing is that Secretary Kennedy doesn't like all of the top-down government guidelines and recommendations in place right now, and wants to replace them with his set of preferred top-down government guideline recommendations. And that I don't like. I think the government, and I don't discuss this at great length in my book, but I've written about this a lot, even recently. There's a legitimate role for government in public health. Public health are things like issues where what you do can affect other people unintentionally, their safety, their health, so for example, dumping toxic waste in the public square, having a highly contagious disease that could be lethal, and you're just walking around in crowds, not being, quarantined. Those are legitimate functions for the government to get involved in, because they're protecting each other's rights from externalities. Okay. But then there's other issues like, what's the best diet for me to have? How much exercise should I get? Should I smoke? How much alcohol should I drink a week? Should I smoke pot, or ingest pot? All those kind of things are personal health issues. I don't see a role for the government there at all. But the government, we've had mission creep, so the government's involved in all those sort of things now. And so when you have the government say this is the way your diet should be, as it did with the food pyramid in 1980,
Which was upside down.
completely upside down, right? But once the government says it, even though they have all these disclaimers saying these are just our recommendations, talk to your doctor. No, because what the facts are, it's a de facto mandate. What doctor is going to have the guts to say they're all wrong? Take my now. Some have, of course, but they're considered quote unquote fringe for saying that. And nowadays medicine has become so corporatized. Almost all doctors either work for a hospital or for some corporate clinic, and they're not going to want to be caught going against the government's guidelines. So even when it's just a guideline, it becomes a de facto mandate. And the only thing they should be concerning themselves with are things where, if I don't do this, I'm going to make somebody else die or get real sick. That's where it's the government's business. But what I do for myself, whether or not I'm getting enough exercise, whether or not I'm drinking to it, that's personal. That's the kind of stuff I should discuss with my doctor or my nurse practitioner or whatever healthcare practitioner I choose to get advice from, regardless of whether the state gives me permission to get advice from them.
Well, you get into that a lot with speaking about harm reduction,
Yeah.
which folks may not understand that as a policy term, but certainly get it with respect to the government restrictions on smoking. But now this contradictory movement to ban vaping. So can you talk about that's sort of insanity?
Right. Well, I'm trying to get this word going. I invented a word I mentioned in the book, nicotinophobia. Hopefully it'll get some traction. But it's this irrational fear of nicotine. That's because most people think that it's the nicotine in the cigarette that causes all the health problems. In fact, nicotine is the addictive component, but it's actually fairly harmless. In fact, the Royal College of Public Health in the UK has said it's basically comparable to caffeine. So nicotine enhances your focus and cognitive abilities, just like caffeine does. It's a little stronger. But unlike caffeine, it also releases endorphins, which have a calming effect, which is why you'll see smokers sometimes during a moment of stress say, wait, I got to have a cigarette right now. They think the cigarette is calming. It really is calming them down. So nicotine is the part that eventually most people are smoking because of that. But the delivery system, which is burning tobacco leaves, has all these tars and carcinogens in it. So in recent years, we've developed these different ways to get people who want to quit smoking to be able to quit. With, first there was nicotine gum, and there's nicotine patches, and then e-cigarettes where you're vaping nicotine. That's been found in comparative effectiveness research, several of them. I mean, it's not even controversial anymore. That's the most effective way for people who want to get off smoking to quit smoking. E-cigarettes.
Because it's the same method of
Yes,
delivery too, right?
because they've developed these habits where they like
Yeah.
breathing in and out. So that's the most effective. But and also that's most effective is the flavored ones. Studies show people trying to quit tobacco prefer flavors over tobacco flavor. So because the politicians think that they don't want kids to be around vapes, they're banning flavored e-cigarettes, which is what the adult smokers want to quit smoking. And meanwhile, e-cigarette use, the latest data just came out. It's almost down to it's dramatically dropped over the years among teens. It's down to about a little over a few percentage points of the teen population. And the evidence is that those teens who are vaping would otherwise be smoking. So
And you quote in your book Senator Schumer having like speaking sort of just
yeah,
ridiculously scaring people
right.
about
That was about Zyn.
that was
So
about Zen.
yeah,
Okay.
so now they have this new product, which is pure nicotine in a pouch you could put inside, between your cheek and gums. And they come in different flavors and it slowly absorbs the nicotine. It's like if you're kind of, having coffee continuously, but it's more practical. And there's some people who really like it. And there's this scare campaign going on. We got to stop it. And of course, if you stop it in a convenience store, you'll see warning labels on the sign saying we sell Zyn here. It's it's actually a relatively safe drug. Now, just like any drug, if you take too much, you could have too much caffeine, and your heart could start racing, and blood pressure can go up. Same thing with nicotine. But generally speaking, over the long term, nicotine's risks are somewhere in the area of what caffeine's risks are. But we've given it this label of, like, we think people just think this is the evil part of tobacco smoking. The unhealthful part of tobacco smoking is everything but the nicotine.
We have some of our audience sent us in some questions. We're going to run through these quickly while we still have a few minutes left. What would the founders think about healthcare today and people's ability to access and the government intervention, right?
I think they would freak out because, in fact, I mentioned this in a book. Thomas Jefferson was speaking to an audience in Virginia about the importance of protecting the right to free speech. And to that audience, he said, and now I'm paraphrasing, especially I didn't speak in 18th century American English, but he said that the right to free speech is sacred. It's as sacred as our right to self-medicate. So it was just understood that, you're an adult, you have a right to put what you want to in your body. And nowadays, it's the other way around. We have to say, no, the right to self-medicate is just as sacred as our right to free speech. It's taken a complete 180. In those days, all the currently illicit drugs, there were no illicit drugs until the Harrison Narcotics Act was passed in 1914. That's when it started. So up until 1914, people were purchasing opium through Sears catalog. And, you know, uh, heroin was a cough syrup that people bought over the counter to give to children when they were coughing. Coughing was keeping them awake. Now, heroin is just the brand name that Bayer gave it. It was the chemical name is diacetylmorphine. It's morphine with a couple of molecules added on.
Less consumer friendly of a name.
Yeah,
Right.
yeah. Well, heroin comes from a German word, heroish. I looked this up. It's kind of like a way of saying, super, like more powerful. So it's like new super improved Tide detergent. So it was like heroin is super improved morphine, works faster and stronger. That's why I picked the name.
This is an interesting question. Would you let ChatGPT diagnose you? And I think just this really is about talking about medical autonomy, your ability to
Yeah.
find out information about your own condition.
That's a really good question. In fact, my colleagues on the health team are and it just beginning to team up with our colleagues at Cato in the technology space.
Mhm.
And we're going to study this together and kind of come up with a paper on this soon. But I think you have a right to consult whatever and whoever you want. I think it will also be there'll be liability questions for the people who run those platforms. They may not want, and then you get into all these legal questions like, okay, so if I got advice from ChatGPT and it was wrong and it led to all sorts of problems, who do I sue? So a lot of these things need to be worked out, but the principle should be, I have a right to get advice from whatever source I want to get advice from. People are sort of doing that now when they're going to quote unquote Dr. Google. I get patients all the time coming in with a list of questions that they got by doing their own research on the internet, which is they should do. I'm not upset about that. So to me, it's just an extension of that.
But this is, I mean, it's kind of like that on steroids now,
Yeah.
comparing it to Google, right?
Not only that, what's that going to do to the licensing regime we have? I mean, that's going to really, just like telemedicine is also creating all sorts of problems. So, I could get advice from, and Arizona is good at that. We allow, and Goldwater Institute was behind that. We allow healthcare practitioners licensed in any of the states to provide telehealth services to Arizonans, but most states don't. So if you live in California and you want to get medical advice from an expert at, let's say, Cleveland Clinic, who knows more about this than anybody, they're not allowed to give you advice unless they get a license in California. So the license is standing in the way of these new technological advances. So these are the issue to me is you should always bring it back to autonomy. What are our rights as autonomous adults? The other stuff is important, and the details may need to be worked out, but that should be the governing principle.
In your private practice, what's the most absurd government regulation or impact of government on your ability to treat your patients?
Um, but to me, what bothered me the most was the government imposed electronic health record system on me. Normally, because in order to be certified by CMS, that we have to be compliant, our electronic health record system has to be compliant. And since it's a one size fits all system designed by people who don't practice, it wastes a lot of our time and the patient's time in the waiting room on these iPads we give them, entering all this information that I don't need for this problem. The patient, I don't even need to know about this from the patient. It slows us down. It's very irritating, and it makes us learn to conform our practice style to the electronic health record. Uh, in every other field, I mean, when a business decides, I think we could probably improve our productivity and bottom line if we went digital. They consult IT consultants who would study their particular operation and design a product that fits around their specific needs to make them better at what they do. And in the case of healthcare, it's in reverse. We have to readjust what we do to fit this template that was imposed on us. I find that the most frustrating.
Last question, are you hopeful that there can be reform? And what, if you could wave a magic wand, what would be the first thing that you would do?
First thing I would do probably, I would go for low hanging fruit, which would be like drug reciprocity for the FDA. When it comes to scope of practice laws, I would expand the scope of practice of a lot of the different ancillary health. I would ideally get rid of licensing altogether. In fact, the Goldwater Institute had a paper out some time ago suggesting, Milton Friedman said this back in the 1960s in his book Capitalism and Freedom. You don't need a government monopoly deciding who could do what. There would already be third-party certification organizations to credential people. You have the American Board of Surgeons, the American Board of OBGYNs, et cetera. These are all private nonprofit organizations that test and credential people. You don't need the government to do that. So Goldwater Institute had a legislative proposal that never got passed, where people are given two options. You could either be licensed or you could be certified by an independent certifying organization. Either track will be okay in our state. And it would list the organizations that they would recognize their certification. So legislation in that direction, I think, would be a really good thing to do in terms of what's doable and practicable.
Well, Jeff, thanks so much for speaking with us today. I really enjoyed reading your book. I highly recommend it to our audience. Your Body, Your Healthcare. Thank you, everybody, for participating. Visit us at goldwaterinstitute.org to learn more about the work that we're doing at the Goldwater Institute on healthcare, ensuring healthcare freedom. And Jeff, a final word for you.
Well, what I'm hoping is after some of my proposals in here might kind of make people take it back a little bit, like when I call for ending the war on drugs and ending the war on nicotine and things like that, and ending licensing, ending the FDA. But if I got, I'm not expecting everybody to just sign on to every one of my ideas. What I'm hoping is that after reading the book, every time they hear any sort of health policy issue debated in the public arena, they have a new appreciation that what these legislators are debating is how they're going to control my healthcare choices and decisions. That's what they're basically deciding. They're not trusting me to make my own healthcare choices. And if I got people at least kind of seeing that, then I mission accomplished.
Well, thanks so much, Jeff. We appreciate it.